Dear viewers, welcome you all to our show, OSA Orthopaedic Solution Academy. Hope you all are well during this COVID-19 pandemic situation by wearing mask and keeping distance with each other. Dear viewers, today our topic is the infected non-union treated by ilizarov. The very important topic. So we want to discuss it more and more, as because of we face challenges to make up the non-union, but sometimes we fail. When we fail, then we have ilizarov, the magic of ilizarov. And today our speaker is also one of the magical speaker and the fantastic speaker of Bangladesh and the pioneer elizarov surgeon of Bangladesh, Professor Mofakarul Bari sir. I'd like to request Professor Mofakarul Bari sir to join with us.
Thank you so much, Tanvi, for a good introduction.
Thank you very much, sir, for joining with us. Dear viewers, we have academic panels with us. Some of them are busy, so cannot join with us still, but they will join, we hope so. But we have a very learned and enthusiastic academic panel with us, that is Dr. Shamsul Huda from Patna, India. I would like to request Dr. Shamsul Huda to join with us. Welcome, sir, to join with us.
Good afternoon. Thank you, Dr. Tanvi, for calling me. Thank you.
Thank you very much. Dear viewers, we always know that the non-union is a very difficult thing and a challenging thing for all orthopedic surgeons. We have to manage these things according to the method of ilizarov. If there is infection as well as non-union, then it will be so much difficult. But we can overcome these difficulties and challenges by ilizarov. But how? That we'll come to know by the presentation of our honorable speaker, Professor Mofakarul Bari sir. So I'd like to request Professor Mofakarul Bari sir to start his magnificent presentation. And the topic is infected non-union treated by ilizarov. Sir, please. Sir, would you please share your screen with us, sir?
Yes. Now it's visible. Can you see my screen?
Yes, sir. We can see your screen clearly and we can hear you loudly, sir. That is perfect.
Okay, thank you so much. Thank you so much, Tanveer and Dr. Shamsul Huda. And before starting my talk regarding this infected non-unions, in one of the our episode, I talked about the infected non-union and at the same time the treatment of osteomyelitis by ilizarov technique. And unfortunately, our boss president and director of the NITOR is not willing to attend probably, or maybe he will be here after a few minutes. Still, I don't know. Then that's why I'm going to talk on this. Today will be difficult infected non-unions. So these are my places. These are my institutes. And this is my Gurgaon Center. This is my Orthopaedic and Trauma Hospital Institute in Dhaka, 1,000 bedded. This is my two places where I'm working now. This is my personal center, Bari ilizarov Center. And these are the things, 4M, I always tell this. And learning ilizarov is like learning a language. Teach alphabets, grammar, improve and use it. Nobody can teach you the biomechanics of the ring. The ilizarov and its uses and various permutations and combinations you should have to know. So you have so many ways to bell a cat based on one experience and concepts, like one's language is different from others. What I myself thought about this one, infected non-union. Arrest of bony fracture repair process with the formation of fibrous or cartilage tissue in between the main fragments. The fracture has remained ununited for 6 to 9 months due to biological or mechanical failure, judged by clinical and radiological evidence, and the infection still persists. So this is not all the time true. Now, what are the issues we can find in case of infected non-union? You can see the bone loss. This is a very big issue. Soft tissue loss, big issue. Infection, of course. Gap non-union, scarring of the skin, deformity you'll find, and at the same time you'll find the shortening. So these are the things you can see, and when patients are suffering, you'll see the patient is almost all the patients, those who are suffering with the big trauma, they have a psychological impaction. And that is the frequently multiple surgical intervention we should do to go for that. And problems of INU, infected non-union, these are the problems you'll face all the time in your day-to-day life when you will treat the infected non-unions. Sinuses, osteomyelitis, bone and soft tissue loss, fibrosis, osteopenia, skin problem that I told you earlier, adjacent joint stiffness, complex deformities, LLD, and at the same time, when you are prescribing a lot of antibiotics, there will be multi-drug resistance. So these are the locations you can see in case of our treatment of the patients. Locations we have all through the followed the Gastineau-Anderson classification, and in that way we have localized our non-unions in this way. So 2 schools of management in case of infected non-union: conventional method and ilizarov method. See a case, 32 years old female, non-union of the right lower femur and segmental tibia. You just look at this, the lower of the femur and lower of the right tibia ipsilateral. Conventional method treated elsewhere. In that way, femur was fixed internally and it was fixed externally. You can see here. And as a result, there is a big gap. The middle fragment is dead, and that was removed. And management by ilizarov fixator and principal, this is increasingly being wheeled for infected gap non-union, since it allows simultaneous management of all these problems. Problems are infection, gap, deformity, and shortening. Simultaneous treatment by ilizarov technique, radical debridement, bone transport, acute shortening, and then you can go for lengthening. What are the strategies? 2-stage treatment. Stage 1, infection eliminations, radical debridement of necrotic and infected tissue. And you can go for antibiotic bits and cements. And in stage 2, deconstruction of the bone and soft tissue. You can go for flap, autogenous bone and soft tissue covering, cancellous and cortical and vascularization. You can go for that. When to open a non-union, to reshape the bone ends for intrinsic stability, to remove something out and to remove in something. That means you should go for bone grafting. In ilizarov, you have 3 modalities of treatment: monofocal treatment, bifocal treatment, and trifocal treatment. Now you can see the tibialization. Fibula osteotomized proximally and fixed to proximal fragment of tibia with ilizarov frame. Similarly, distal osteotomy and fixed to distal fragment of the tibia with ilizarov frame. Now, what is corticotomy? You know that one. Low energy osteotomy with the preservation of periosteum, endosteum, and the bone marrow. In choosing the corticotomy level, anatomic, biological, physiological factors must be considered all the time. Now, this is the monofocal bone transport. You can see regenerate bone, how this is coming down. You know it. This is the bifocal bone transport, regenerate bone. based on few basic principles which you have to go for the surgery. Number one, you shall have to take the biopsy culture. All necrotic and non-bleeding bone must undergo debridement. A high-speed bar is used to debride the bone, and continuous cooling irrigation is applied to the bar to decrease the thermal injury. The tibial cortex experiences very little bleeding. We must look for the paprika sign. And all patients are treated with 6 to 7 antibiotics that are specific to culture organism. Now, these are the strategies. I always try to follow this one. This is, you can get the measurement of your bone, location, and how you can do all the cases. Because I love to do the ilizarov, you have got other options. Paprika, other options, you can go for that, but love to do this in all these type of cases. Now, methods of elimination of pullular cavities. Filling of a pullular cavity with one of the fragment ends by gradual transposition of the fragment constituting the cavity. Filling of cavity by shifting of a cortical wall. This is the results. I would like to show you that. Just see in case of we have done in my last lecture. I told about that 545 total cases, but today I would like to talk on only the difficult infected non-unions. 248 patients, excellent results. You can see 152 good results and 46 fair result, poor in 2. It's very little. Now, I'd like to share my experiences with the ilizarov techniques. Some of the cases difficult. This picture I have shown you in my lecture. Startingly, I have shown you this one, non-union of the right lower femur and segmental tibia. See, treated elsewhere. Now you can see, I have shown you this picture previously. Now, this one, how chart out the plan of the action. You can see she was treated elsewhere, outside my country, not inside my country, outside my country. You can see here red marking with double plates, and this is my Nigerian fellow. Yes, and then I remove all this plate, and this is broken. Fibula grafting was done. That case that I have shown you the previous X-ray. See the fibula, it was done like this way. Now what happened? Infection, and I have removed the plates and screws. Then I put a guide wire here, guide wire, and double corticotomy here and here. You can see just for lengthening, and you can see I have not used any shunts. One ring, one ring, one ring, and one ring. Gradual destruction and compression. And during treatment, this is after 1 year follow-up. You can see very bad case it was, difficult case. Now, from this situation to that situation, you can see here. From this situation, just like this, see the big bump, deformity, and then finally after removal of the apparatus, and this is the union. Clinical appearance, 1 year, 2 months follow-up. So what to do? Gap non-union bad case. The more difficult the case, the more is the ilizarov. Ilizarov keeps you safe all the time. If you know the principles and method properly, plan it to realign. Preoperative planning is very important in case of ilizarov difficult cases. The power of planning is very important all the time. Now see this one. 17 years old boy, post-traumatic right big gap, femur. Femur. This was an interesting case. Probably I told you that time. He took this bone. This is the whole bone. Fell down in the street. He took it, and his relative came to my place. Sir, I have taken the bone you put inside. So is it possible? This is not only the femur, but at the same time you can see pilon fracture. ipsilateral. Then you have treated also elsewhere. The big, here you see, I have put the ilizarov with telescopic rods, very big gap, done the corticotomy here, lengthen this part. In the same sitting, I have done here the correction of the pilon fracture, and then see how much lengthening is going on from this side. It's very big. And distally, there is only a little bit bone here, lower part. Here, only periosteum, I think so, remains, but no bones, nothing else. And fortunately, we are lucky that there is no vascular injury here. And now you can see the right side, after 4 months follow-up here, how this gap was increasing, this one. And this is coming down, compression destruction apparatus. Now you can see here, he is walking with the apparatus, and this is totally lengthened part, and this is a minor bone, just look like. But I have seen in under Siam that this is not too much stable. Then I decided to go for the, again, corticotomy in the lower part of the femur. And I have done the corticotomy. Now you can see from here, this is full gap is reduced, and this is coming up a little bit, now remains here. Full, it was 24 centimeter shortening of the femur. And final X-ray, I will show you later on. Okay. This is the lady, you can see, 40 years old woman, segmental fracture, difficult non-unions all. See the femur, see the skin condition, uniaxial fixator, treated elsewhere, came to me with this. Then I took it as a challenge and started treating. Keeping the axial fixator, see, I am putting the wires and ilizarov, and proximal part of the femur, this is the shunts, this is the shunts, two shunts. It is very easy for the patient, so the patient can easily lie down in the cot. And for the femur patient, you must have a special cot so that they can easily lie down there. And during treatment, you see, after 5 months follow-up, and this is, you can see here, I have transported the fibula to the tibia, protibia, that is called protibia, that all tibialization. And then look at this. Femur is now quite okay, almost. And this is also regeneration is going on here. And this is the, from this situation, see dear friends, from this situation to this situation. Now, clinical appearance of the patient. Now, after 7 months, clinical appearance. From this to this, look at the femur, look at the tibia. Oh, wet case, again, exposed bone. You can see the color of the skin, color of the bone, and color of the muscle. Next, you can see here, I have put the guide wire, and this is rotational view, you can see, big gap, and by 2 olive wires, I am pulling from that side, upper part, that was a fracture. I have not done any corticotomy there. From that part, I have started doing destruction. And this is the ongoing process after 3 months follow-up. This is after 5 months follow-up. And this is, you see, after 6 months, from that bad situation to this situation, you can easily imagine how we can solve this kind of difficult problems with magical ilizarov technique. Now the patient, after removal, after 6 months, see, and before coming to my place, He was treated in another hospital and they decided to go for the below knee amputation. And this is the beauty of ilizarov, you can see. This is the beauty. Now look at these gentamicin bits used with interlocking nails. Patient with infected non-union, difficult case in the femur. Femur is always difficult. So I removed the gentamicin bits and at the same time removed the nail. And then I have put, see, some are uttering all the time, the ilizarov is cumbersome in the femur. See how he is walking. Even my patients are doing exercises, climbing with ilizarov fixator in the femur. Look at this, only two shunts, and here distal part, all the wires are olive wires. And then this is the final outcome you can see here. Before, now this lateral will see full consolidation. Patient is happy. I am also happy. Big gap non-union right side, lots of difficult case. Near the joint, near about. See, treated elsewhere. Then came to my place. This is treatment. Put the guide wire. I put the guide wire. I always do this. Put the guide wire. This is the guide wire. And then go for corticotomy. And it will maintain your axis. Nothing to be worried. Simple K wire. See, the skin condition was so bad. Skin condition was so bad. Now, as a result, see what happened, this condition. And from this situation to this situation, your guide wires is showing you the pathway, how you can go. So this is the, after 9 months follow-up, see the regenerated bone here. And from this to that, after 11 months follow-up. Bad case. Again, infected non-union in the tibia. Big gap. See, from here to here, more than 10 centimeters. Same. Good regenerate. Now you can see, very good regenerate. Very good. There is a problem in the ankle. Movement was restricted a little bit. Again, bad case, comminuted fracture. Gastrio 3B, tibia, treated elsewhere, and then came to my place. And see, from here to here, 2-level corticotomy. And this is the final view after 11 months. Total full correction and patient is happy. Okay. You can see here, this is the beauty of ilizarov. You can solve all these difficult problems, difficult cases. Now, this is the a little bit, there is infection. To control infection using the ilizarov wires, console wires, you can control the infection by pulling the console wires from one cortex to another cortex. This is another case, you can see. 70 years old male, difficult case. There is no viable bone. There's a big gap. See the right side here. If you look at this in the plain X-ray, you will not be able to understand that this is a dead bone or normal bone. This was a dead bone. This is an exposed bone. He came to my place with this uniaxial fixator. And then I have removed. See the full gap. Full big gap. Remove everything. Ring here, and then gradually I have started distraction. Whenever you start distraction, you will get a very good tissue genesis, neurogenesis, angiogenesis, everything, myogenesis, and lots of Schwann cells, neurogenesis. Look at this whole bone, 70 years old, male, after treatment of 8 months. From that situation to this situation, see the bone quality, see the good regenerate bone, and now he's working. He's working after 3 years. I always try to follow the patients minimum 3 to 5 years. Good. See the gastrilo 3B, exposed bone, difficult infected non-union. Initially, I have put the 2 rings here with telescopic rods, a little bit granulation at day 1. This is the day 1 after the just surgery. And then gradually, we have covered everything and lengthened. We have transported the fibula, Tibia. It was done in 2014. See, this is after final follow-up. You can see the whole tibia. This is massive bone now, the whole fibula and tibia. Swan bone is working without any pain. A little bit limping, that is, it doesn't hamper the patient. So this is also published in American Medtrip Journal, infected gap non-unions of femur. See, this is a, I rather I will say that this is a gastric 3B, injection fixator cannot help anything here. Then during treatment, if you apply the ilizarov apparatus properly, you can get good outcome. So this is clinical appearance of the patient. Look at this, double plating, difficult case, screws and discharging sinus, and pus was coming all the time. Then I have removed, put the apparatus, and he's oh, really. This is the beauty of ilizarov. See? Okay, I'll proceed. See, look, 1 year, 3 months. This is also fidelity, non-union tibia in Medtrip Journal. Look at this, very big case. 30 years old male patient, infected non-union, right radius. Now you can see, he was treated elsewhere. From here, 3 pictures you can see, left side first, then he came to my place with that one, middle one, then I started treating. Lengthening of the radius. See, again I go back, then you'll be able to understand. See, whole ulna was totally gap, very big gap in the ulna. Now you can see how I have lengthened the ulna, and that one radius was almost okay. From here to here, you can see the beautiful consolidation and lengthening. That the gap was very big after 1 year follow-up. The patient is very happy. These are the normal cases, I think so. Though it is a normal infected non-unions, not so difficult. Just remove, put the ilizarov. Just remove, put the ilizarov. Just remove, put the ilizarov. Now see the bone quality, and after 6 months follow-up. This is a little bit difficult. This I put a guide wire inside so that it doesn't deviate. And then this is the final follow-up from that situation to that situations. This is a difficult case. Look at the radiation ulna, young lady. Removed everything. Rationale also removed. And then with ilizarov fixator. It is not very difficult to put ilizarov in the forearm. So look, see the union, bone quality is good. This is final follow-up after 1 year. What are the merits of ilizarov? Biological and mechanical method. Biology is the king. weight bearing is easily possible, minimally invasive, feasible in the presence of escarified tissues and the presence of infection. There is no need of free or local flap, no need of graft from iliac crest, so no donoside morbidity. Only one demerits, I tell all the time, I don't see any demerits. Only one demerits is greater learning curve. That is, till death, you should have to learn ilizarov. Still, you are learning. I am a student of ilizarov now. Still, I'm a student. I'm learning. I don't know everything, but I try my best to do something with ilizarov technique. So, greater learning curve is a very difficult, very demerits. One of the demerits of the ilizarov. Otherwise, I don't see any demerits. A well-planned step-by-step ilizarov technique to cover infected non-union of the femur and tibia is an excellent method in challenging cases. Excellent results cannot be achieved with conventional methods, but can be easily achieved with ilizarov technique within 1 to 2 years. So before doing any ilizarov surgery, difficult surgery, you should have to tell your patients, counsel your patients that this will happen, it will take time, but if you want to minimize this very big gap, without ilizarov, I don't see better options. This is my conclusion. And at the same time, I always love to show this one also. What are our known knowns? There are known knowns, there are things we know. There are known unknowns. That is to say, we know there are some things we do not know. But there is also unknown unknowns, the ones who don't know, who don't know. This is also very important. See, what is peace? This is called, in Kurgan Center, you can see how the beautiful girls, see, this is called ironing exercises. They're bound to do this kind of exercises with the physical instructor. And this is in my right side, my center, they're also doing the exercises with a special cot. See, this is also, if you put ilizarov in the femur, difficult case, your cot must be like this, with recess, with gap. Otherwise, this will discomfort the patient. Patient will not feel any good situations. With this, patient can do at the same time with his hand exercises, and your femur will be in the gap. See, same also. Doing exercises, a special part, exercises. These are the varieties of patients, those who are doing exercises with ilizarov apparatus. Lots of videos are here. So I'm waiting, see in the femur, especially in the femur and in the tibia, both legs, both sides, you can see here, they're doing exercises. So you must always advise your patients so that with the ilizarov apparatus, they can go for any kind of exercises, and they must check their apparatus every day. And this is the, if you follow this kind of instructions, then the outcome will be good. And probably these are the things that I wanted to show you regarding the infected difficult cases, almost the difficult cases. Next slide, I see. This is not moving. This is, see, my patients are climbing in my physiotherapy department. Fundamental principles of ilizarov methodology is load and motion. And this is the genius, the man who made it all possible. Great scientist, written in Russian in his graveyard, talented doctor, gifted innovator, creator of the apparatus and the methods of transosseous osteosynthesis academician, Russian Academy of Medical Science, Gabriel Abramovich Ilizarov. Ilizarov method is not hard to learn, but it does take proper knowledge, effort, devotion, patience, practice, and intelligent, meticulous follow-up from time to time. If you really want to do justice to your patient, you should opt for it. These are the things I tell all the time. Easy, difficult, impossible in your life. My center's patients, recent patients, these are all the recent pandemic time with masks, you can see. But I don't allow now a lot of the patients. And always love to show this one also. If you have evidence, you have science, you have art, surgical skill of the patient, technology is very good for machines like computers and telephones. But in a human body, we need to go a step further. That is we call biology. Thus, all technologies have to be biologically oriented, and that can be done by ilizarov technique. It's not always essential that a costly technique is more advantageous. Let us be the leaders in advocating biological and cost-effective techniques the globe might appreciate, and we can do it. And in my country, Bangladesh, ilizarov is holding a very strong foothold, and we are doing lot of cases, difficult cases in our countries. Until today, I have 81 international publications, international, 46 in Medgrave, 20 in Juniper, 15 another in Kurgan and other countries. Thank you so much. These are my lovely pictures with all my mentors, my friends, Novikov, you can see Shepsov, Natalia Shikolova. These are the from center in my village, not far away from here. Novikov, Shepsov, Shikolova. You can see the Plushin, they are in my center. So finally, dear friends, I'd like to convey my gratitude and thanks towards these two people, Gabriel Abramovich Ilizarov and Professor Shepsov. What I learned from them, the discipline, the way of thinking, the rigorous approach, truthfulness, sincerity, devotion, and dedication, all these form the basis of my academic career in my life. Thank you so much for your kind attention and hearing.
Thank you very much, sir. Thank you for your brilliant presentation. I would like to request Dr. Shamsuludda sir to discuss about the presentation, or do you have any questions regarding the presentation?
Oy.
Thank you, Dr. Tanvir. Thank you, Bari sir. It was a wonderful, wonderful lecture. We always learn whenever we listen to you. You are mentor, sir. This is a very wonderful lecture on ilizarov for infected non-union. We always regular do ilizarov because it's a wonderful machine when no machine works. I just have one question, sir, here. That when we have a delayed regeneration, we do piano accordion method, we do blood substitution, and at times I also use teriparatide. So what is your take on use of teriparatide in the case of delayed regenerate, sir?
You repeat the question again, please. Repeat the question again.
In case of bone transport, and delayed regenerate, what is the use of what is your take on use of teriparatide versus this piano method, sir?
Is if delayed regeneration, then you can sometimes go for accordion method, compression and distraction. Compression for 7 to 10 days and go for distraction. Or you can put autologous blood in that place. 3 to 5 cc blood take from the patient and you can put there. And gradually you start distraction again. This is the method.
Yes, sir. What is your take on use of teriparatide in case of delayed regenerate, sir? Teriparatide.
Teriparatide?
Yes, sir.
What kind of teriparatide? I don't know.
Sir, teriparatide, sir. Teriparatide.
Teriparatide. What is that, Uda?
Sir, that is a we use sometimes for better regenerate, but we have been using not in all the cases here. Frequently, it has been helping.
What do you do then?
Voice is interrupted.
What do you do then?
It helps in
What do you do?
bone meshwork increasing, sir. Teriparatide, sir. We have used a few cases of ilizarov. It has helped, but there has been controversy that it helps not, sir. In India
I
also.
don't have idea about the teriparatide. I use this one, and in one of my lectures, I told you that I go for in tibia, in metaphyseal region, I go for drilling, and distally and proximally,
Right.
to increase the circulation of the whole limb. Okay.
Right, sir. Thank you, sir. One more question, sir. In long transports and infected or around joints, so have you faced the problem of joint stiffness?
Yes.
And what should
Yes,
be the
that
method?
is very.
Yeah.
Yes, that is very important. That's why I am telling you, when you are near the joint, you are going for distraction because you are pulling the muscles around the joints, soft tissues, and that's why you are getting the stiffness. That's why you should have to go for regular physiotherapy, physical exercises of the patients with the ilizarov apparatus. And unfortunately, in third world country, we just put the ilizarov go and no. Rehabilitation after the removal and before removal is very important. In Kurgan Center, they have a 70 beds only for rehabilitation. All instructions they are doing. And in my center, I'm also doing that. I give the instruction to the physiotherapist. I have 3 physiotherapists, 1 lady, 2 men, and letter everything. And I tell them go for exercises. Even those who are admitted patients, they are also doing the exercises. This is the main thing. For ilizarov surgery, all the time, the basic principles, if you don't follow, everything will be crushed. Basic principles. And most of the ilizarov, those who are not doing ilizarov, they're criticizing because this learning is stiff. Criticizing because why they are criticizing? If unknown person doing ilizarov or unknown orthopedic surgeon having any basic knowledge on ilizarov, doing ilizarov, then that patient came to another orthopedic surgeon who is not ilizarov doing, who is not doing the ilizarov. Whenever he sees this kind of ilizarov activities done by another surgeon, then he became, what you have done, this is not a good method. That's why our motto and our message should be that before starting ilizarov, please go for the basic. If you have basic, then you can go for difficult cases. No problem.
Thank you very much, sir. Thank you very much, sir, for sharing your knowledge with us, sir. I have one last question. That is, you have told that you are using the console wires to control the infections. Sir, console wires, does it pierce 4 cortex or does it pierce only 2 cortex? Number 1
cortex.
question.
Yes.
2 cortex. And the second question is, do you give tension to the console wire or not giving tension to the console wires?
Okay, very good question. Console wire means, I'm showing this. Can you see this? No.
Yes, sir.
This is your bone. This is your bone. This is your bone. Whenever you are putting the wires, go from this vertical, this perpendicular,
Yes, sir.
this perpendicular. 1, 2, 3. Here your skin is very bad. Here is the infection. So you put one wire from here to this cortex. From one wire from here to this cortex. Just you fire the first cortex and go up to the last cortex, first and second. Okay, don't go beyond that because you have a X-ray or you have a C-arm. If you don't have C-arm, even you will feel when you are piercing the second cortex. When you go through the medullary cavity, you will be able to understand that I am going in the open space. That is very easy. First cortex, then go to second cortex, then put another wire, first cortex, second cortex, then another wire. 4 minimum where if you put cortex to cortex, then you fix these console wires with slotted bar and with the there is a plate, long plate, and gradually you pull 1 millimeter per day. Pull. What you are getting? When you are pulling gradually 1 millimeter per day, you are getting new vascularization around that one, around this one, whole tibia. The area that you have put the console wires. This is and as a result, you are getting new vascularization. What will happen? Your color of the skin will change. Infection will be controlled. If you have new main thing of ilizarov is the new vascularization. One you have put from the perpendicular from this, and another 4 wires from vertically. You go 1, 2, 3, 4. Then this pull. You understand? Or you can put 5, 6, depending on your case. One from perpendicular, another from this transverse or vertical. Am I clear?
Yes, sir. Yes, sir. Thank you very much, sir. I think it's an excellent procedure for neovascularization. Thank you very much,
In
sir.
osteoarthritis case, non-union case, sometimes patient coming with ring sequestrum. You will feel coming discharging. They are irritating. Sir, ring pus is coming. No, this is not pus. Something is coming from fluid, and then you just curate and put this Sklushin, Professor Nikolai Mikhailovich Sklushin, he is the head of the osteomyelitis, only one man in the world. He is doing all these kinds of infection. That is osteomyelitis center in Kurgan, but that is separate building. Osteomyelitis separate building totally. They have in the same area, but separate building. So they are treating like this. So ilizarov, any question? No question. Samsudda, okay. We have already.
No, sir. Thank you very much, sir, for sharing your great knowledge with us. And it's a great pleasure with us to learn from you and to hear from you. I'd like to thank Professor M Bari, sir, as well as Dr. Shamsuddin, sir, for being with us. Dear viewers, I hope we'll see you in the next Friday with another topic. Till then, I'm Dr. Mohtan Ashraf saying bye-bye to you. Have a nice day and have a safe day. Assalamu alaikum.
Thank you very much. Thank you very much.
You are watching Raj TV, Jagorone, Bangladesh. Please subscribe our channel.